Hi everyone, and welcome to the NG podcast. I'm your host, Marcus Einson. In the NG podcast, we aim to bring you content that's of interest to anyone involved in enteral feeding, whether you're a healthcare professional, a patient, or a carer. We hope you enjoy the NG podcast, and if you do, please subscribe or like or both on whichever platform you're viewing or listening to it on. So today we are welcoming Liz Anderson to the NG podcast. Liz, thanks for agreeing to speak to us today. We really appreciate you taking the time out of what I think is a week's annual leave.
Yes, it is actually. Oh, that's okay.
Well, that's even better. hence the lack of uniform.
Yeah, that's it. Yeah, sorry about that, everyone. I'm just completely in civvies in my conservatory without caring.
The light's very good. I have to have artificial here. So before we talk about the main subject of the day, for the listeners, hopefully there will be some who might not know you, perhaps you can tell us a little bit about your role as a lead nutrition nurse.
Yes. The best way to explain it is how I explain my position in my organisation to patients and colleagues I'm teaching. Dietitians work out what goes in, nutrition nurses work out how to get it in. That's the simplest way. So within my job, that encompasses the three types of nutrition support. So that's oral nutrition, obviously. That is enteral, which is via the gut, and parenteral, which is via the bloodstream. My role within that is to make sure that the right nutrition gets to the right patient at the right time, using the safest and best method for that patient. So I run my own caseload of complex patients who've got all sorts of issues. So they've got they've got comorbidities, or they may have conditions which means they need to be fed enterally. I also look after patients on the wards who've got complex nutrition issues. I troubleshoot them. I support the staff with NG tube placement, positioning. I teach. We run 8 study days a year for nutrition within our local organisation. Writing policies, guidelines, particularly at the moment, standard operating procedures around safe nutrition. I've written, I'll tell you what, SOPs, as we call them, are the way forward because they're brilliant. So that's me. I cover 2 acute sites plus some patients in the community, and also I have got a colleague in the community who does a couple of days a week. Jan, she does 2 days a week in the community as well. Between us, we very much work within the MDT. So I work with doctors, occupational therapists, speech therapists, obviously my lovely dietetic colleagues, nurses, facilities management. Nutrition's everywhere. Yeah. I mean, it's just everywhere. So I kind of have a finger in a lot of pies.
Yes. Yes. And actually, speaking of fingers in a lot of pies, I've known you for a number of years, and through some different iterations of my career, but I know how passionate you are about making sure every patient gets correct nutrition. So can you talk a little about the organisations and campaigns you've been involved with, outside your day job, if you like, and perhaps the ones you're still involved with?
Yeah, I am passionate about nutrition, and it's been going on, I think, probably since, I was a staff nurse on a surgical ward, and I'd been on nights for a number of years, and I came back onto day duty. This was going back to the 90s, and there was a patient on there who had a twisted gut, and he'd gone through quite a lot, surgeries and what have yous, but nobody had ever thought about his nutrition. Nobody had ever thought, like nowadays, I can say this confidently because we have got nutrition teams and people know a lot more. He would have been on some sort of artificial nutrition support, but in those days he wasn't, and he lost like 2 stone in, I'd say, about a month. which was shocking. You just saw this man get thinner and thinner. So that first sparked my interest into looking as to what happened within hospital environment and people losing weight. And then in 2006, Age Concern released a paper called Hungry to be Heard, and it was about older people's experiences in hospital. Now, I know that my lovely colleagues who were in the NNNG at the time will forgive me for this, because what happened was I was so incensed, and I had just recently joined the National Nurses Nutrition Group, and there was nothing about oral nutrition. It was all about tubes. Now, obviously I've been in the NNNG a long time. I now know that it wasn't just that, but that's why nutrition nurses originally came into being, for parenteral nutrition.
Yes.
So, to cut a long story short, I wrote an email on our forum saying, I don't understand why you're nutrition nurses and none of you have commented on this paper. To cut another long story short, it ended up with Andrea Cartwright, she was chair then, contacting me and asking me if I'd take part in a debate about the importance of oral nutrition at the NNNG conference. And I can't remember what year that was, 2006, I think, I can't remember, 2007. I then became a committee member of the NNNG. And the rest, as they say, is history. I became a committee member. I then got involved in lots and lots of strategies and policies, and the nutrition plan, I think it was in 2007, the government's nutrition plan, I think it was called, came to naught, really. It didn't. And there has been countless since. It's difficult to say. So obviously the hospital food and drink strategy I was involved in, but my main thing really has been NG tube safety, and that's been, obviously when I was with the NNNG, we wrote lots of guidelines and best practice guidelines around anything to do with artificial nutrition support. NG tube safety is a huge bugbear of mine. And I think within the last few years, that's where I've really been concentrating. But at the same time, my other passion is the patient, obviously. And I think sometimes within specialities, you lose track of the fact that there's a patient at the end of that tube. So, yeah, I mean, I've done loads. Because I'm passionate and I enjoy it. And I just think that every time I speak or write a paper or something, maybe just somewhere somebody is thinking, oh, okay. And yeah, I do put myself out there, but only because I just really want to make things better for patients and nurses as well. Yeah.
Well, thanks for that summary. I could probably add a few more things, but I won't today. So we could talk about a whole range of subjects that are related to nutrition nursing, but today I'd really like us to focus on the issues you covered in a recent article in June in the Nursing Times that was entitled "Ensuring Patients with COVID-19 Receive Good Nutritional Care." And I would encourage anybody who's listens to this to go and get that article and have a look at it. You raised a number of issues in it, but perhaps we can start with how nutritional assessment can be affected in COVID-19 patients versus the non-COVID population. Are there any changes or considerations to nutritional assessment that clinicians should be aware of?
Yeah, so if we're talking about, the patient with COVID-19, to be fair, will have a lot of characteristics as any patient who's got an acute respiratory disorder. But there are certain characteristics that these patients do have, and the main one is that they lose their changes to their taste and smell. Now, we know that the latest advice is one of the warning signs that you might have COVID is that you lose his sense of taste and smell. What you don't realise is, and I only know this anecdotally reading, but also I've got a few friends who, thank God, they have got over COVID, but they still say months later they've lost that taste of smell, a taste of sense and smell. So that is one of the crucial things that you have to think about when you're doing that initial, as a nurse, when you're considering what that person needs. Other things, coughing. People are left with a chronic cough post-COVID. We know this. And we know that we're learning all the time that people are months and months afterwards are still getting the chronic cough. Sometimes they get headaches still. They don't have that sense of taste. And these things are going to cause people not to want to eat and drink. Now, that's bad enough in a healthy, not healthy, but a patient who hasn't got any other comorbidities. So God forbid, if you or I, touch wood, got COVID tomorrow, I would hope that we would recover and hopefully wouldn't need a hospital stay, but we will lose weight because you don't want to eat. You feel you just feel terrible. So we'll lose weight, we'll have no sense of smell, we'll have a taste, we'll have a cough, we will have a fever, obviously, we'll have a temperature, we'll be breathless. So all of those things, yes, they're common in other patients with acute respiratory disorders, but with COVID, they are more likely, and that's why nutrition's so important.
Okay, so that's I think a really good summary of why C19 patients might be more likely to need nutritional support. And does that extend out into the community as well, after the acute phase?
Yes. Oh, and that's what I mean. That is when we're going, that is the really risky time, because if they're in hospital, and this is what we're beginning to find, because this disease, this condition is just evolving all the time. If they're in hospital, obviously they are 9 times out of 10, if they've got a pneumonia due to COVID, they will be enterally fed because of the fact they've lost their swallow, etc. They come out of hospital, they've lost weight, they're in the community, and those things will still apply. And this is tricky because a lot of these patients will have comorbidities. Sadly, they will. So they'll be frail, older people, and they are starting off in what I call negative equity before they even was admitted to hospital. And when you're feeding them in hospital, you're literally just keeping them going. When they come out of hospital, you need to get them to put that weight on again. If they are obese, of course, you need them to get the nutrients, but not necessarily with what I call the empty calories. They need the protein. So there is definitely a role for good oral nutrition supplementation in the community, and I think that's a challenge as
well. The things you discuss in the article is that COVID-19 patients are more likely to need NG feeding, and you've touched on that already, but is that something anecdotally that other nutrition nurses are talking about around the UK?
Yeah, it is. I mean, and actually BAPEN, we know this, because if a patient is sick enough to come into hospital with COVID, then the chances are they may have already developed a pneumonia, which means they are going to have problems with swallowing because they are weak, they're coughing a lot, they can't manage their secretions, which gives them a higher chance of aspiration. So therefore, they may well need to go on a modified diet with our wonderful speech therapists who, can I just say this, they are the unsung heroes. They never, ever get a mention. They've been on the wards wearing all the PPE. They've been there every day. Somebody has to assess these patients' swallows. So we'll just get that plug in.
Yay, absolutely.
Because they're brilliant. And so that is why we just anecdotally at the moment, I'm sure there will be studies, if not, they're already going on. And yes, these patients are more likely to need NG tubes. They don't all end up going to ITU, but again, from my own practice, I have had referrals or advice about patients who perhaps have got they're too tired and weak to eat, so they just can't keep up their calories, their nutrients, or B, they may well be going to be ventilated. And post-COVID, post-ventilation, a lot of people, when they've, I mean, you know, you've probably seen the adverts and the pictures on social media about what a ventilator really is. It's not a nice, polite little tube that sits in the back of your throat. It's quite brutal, and it can actually cause temporary swallowing difficulties. So when they come out of ITU, they will have swallowing problems. So yes, this is why we think there's a lot more people who are going to be fed enterally and it's great. I mean, if somebody is sick and they need nutrition, the fact is people are recognising that. And it would be interesting to know what would have happened 20 years ago.
Yes. Yeah. So there's an increase in the need to enterally feed patients in the acute setting. What challenges does that increase present to people on the front line of care?
So talking locally from a nutrition perspective, nutrition nurse perspective, the biggest challenge that we had nationally, and I know the NNNG have put some stuff out, was there just weren't enough feeding pumps.
Wow.
There just weren't enough. So there were having to be, everybody did things differently, and a lot of patients had to be fed either by bolus, which is when you just put measured amounts in over a period of time with a syringe, or good old gravity. And gravity feeding is literally, you run it through a giving set, you hang it up, and it's a bit like the old-fashioned IVIs, so that it will just drip in slowly. So what nutrition nurses were having to do, again, and this is just going on the forums and just talking to colleagues, and dietitians as well, we were having to teach people how to set up a gravity feed because they'd never done it. And interestingly, some of our overseas nurses who were more used to doing this were like, I can do this, this isn't an issue. But it makes you realise how much you rely on technology. So I would say the gravity feeding was one of the biggest challenges, but we did it. Those nurses on the wards, they took that challenge up. It wasn't brilliant, but they did it because all of the pumps were relocated to the ITUs.
Yes.
So locally, we had our patient. We had a couple of patients who were diabetics, etc. And there were some times when we had to have them. But on the whole, all of those pumps went to ITUs, which gives you the indication of how many patients were enterally fed.
Wow. Yes. So with insights like that as to what happens, are there any other areas of practice that you think might need to be addressed in general rather than just in COVID-19 patients, if you like, to prepare for if this happens again?
Well, that's the main thing I can think of, and probably when I finish this interview, I'll think of another dozen. But the main thing I think is definitely the whole gravity feeding, bolus feeding, is getting our staff trained up to manage that. In terms of NG tube placement, again, it was having to make sure. I mean, we had a lot of nurses that were upskilled. I don't like that word because it kind of infers that they weren't skilled before, but they're learning different skills.
Yes.
And a lot of them were specialists, nurses, working in areas where they didn't actually need to pass NG tubes.
Yeah.
Now, locally, I can't say for other people, but what we did was we had a 2-tier training. So those nurses were not expected to pass NG tubes. They were taught how to care for them, and taught how to test the aspirate for ongoing care and how to troubleshoot. But the actual passing of the NG tube was not done by them. So moving forward, that's something we can do to make, and that's certainly what the BAPEN NG tube position paper says.
Yes.
It should be done by professionals who are doing it regularly.
Yes. Yeah.
And who can become skilled operators. So I think that's something we take out of COVID, is you don't need everybody being able to do everything. I hope I'm not contradicting myself, but it's important that moving forward, if this happens again, we should be able to hit the ground running from that perspective. But you would never have guessed this time last year that we nurses, particularly nutrition nurses and dietitians, would be working together to write standard operating procedures for gravity feeding.
No. But I think I completely agree. I think in any area of practice, if you're going to do something that's not, you should be doing it frequently, because then you do get good at it.
Yeah, exactly.
So we touched on the BAPEN there. Now, my next question is what maybe a bit of a bone of contention. One of the things in your article that caught my attention was the difference in view between Public Health England and BAPEN with regards to the insertion of an NG tube being an aerosol generating procedure. Can you explain what the difference in view is and what BAPEN suggests?
Yes, this is fascinating. So back in, gosh, March, April time, I think it was, Marcus, Public Health England put out their latest guidance, and it said that anything which caused sputum to be produced was, in fact, an aerosol generating procedure. Mm-hmm. And an aerosol is something that's sort of, comes out if you cough or sputter, what have you. So we had a look and we thought, well, hang on a minute. Any nurse or doctor who passes an NG tube will tell you that the minute you stick a tube in someone's nose and it hits the back of their throat, they retch and they cough and they sneeze. And if you are putting an NG tube down, you are you're not within a meter. You're within a meter. Okay, you're well within 2 meters, and you're within a meter, and therefore you are going to be at risk.
Yeah.
So this is when we first started talking to other organisations. So the updated intercollegiate. I can't say it.
Intercollegiate.
That's the word. The updated intercollegiate general surgery guidance in March, endorsed by the Royal College of Surgeons of England, Glasgow and Edinburgh, said nasogastric tube placement may be an aerosol generating procedure. AGPs are high risk and full PPE is needed. Gastroenterologists say endoscopies, you put an endoscopy, into somebody, they're going to cough and splutter. The British Dietetic Association says exactly the same thing. The Royal College of Nursing support it. Public Health England, I'm not sure why they consider it. I think they're going on an evidence base that's quite kind of weak. So we have actually, Barry Jones has done most of this, Dr. Barry Jones from BAPEN, and this has now gone up to the World Health Organization from a group of us, led by BAPEN, yes, but there's a lot of us on this list who say, do you know what? We think this is an aerosol generating procedure.
Yeah.
And you talk to any nurse at all, and they will say, well, of course it is.
Yeah. Yeah, and so that I guess difference of opinion relates specifically to insertion of NGTs.
Yeah.
Is there a difference? Do you think there's a difference between that and checking NGT placement using aspirate?
No, because I'm not sure. I've checked a lot of obviously aspirates in my time. I'm not sure how just taking some aspirate out is going to cause an aerosol generating procedure. It shouldn't make a person cough just taking it out because the tube's already down.
Because I think it's probably just because we're talking about it, it's really important to differentiate that for people who aren't as experienced as you with NGTs. So insertion, BAPEN, number of other organisations think it is, but actually the argument does not apply to routine checking.
No. Arguably, you're going to, if you've got a patient with COVID, you're wearing full PPE anyway. You should be with the full PPE on. If they've got COVID and they've obviously got respiratory symptoms, you would be wearing that full PPE. But generally, just for, you're aspirating with the syringe, you're not doing anything.
Yeah.
Happy to be proved wrong on that, but it's not something I've ever considered.
Now, one of the other things that has been spoken about extensively and you cover in your article is the difference in management of NGTs in patients with COVID-19 who are often been nursed prone or supine. What are the considerations for these patients as opposed to how NG-fed patients are usually positioned and managed?
I think the biggest issue is with proning. It's that risk of aspiration, because obviously the patient is lying on their stomach, and it's that risk of aspiration of kind of the stomach. What's the word I want? Acid going back out of the stomach is what I'm trying to say. And therefore, what BAPEN suggests is we only prone in intensive care.
Yeah.
Okay. We don't prone anywhere else. Yeah. So therefore, when you're proning in intensive care and you're feeding a patient, there are certain things you need to do. So an hour, I think it's a BDA special group for acute and critical care, have done a brilliant SOP for this. So an hour before you're due to prone the patient, you turn the feed off. Mm-hmm. That reduces the risk of leakage back into obviously from the stomach into the lungs. Then the patient is proned, and then you start feeding the patient again. You put them in the reverse Trendelenburg position, which in other words, they are feet down, yeah, that's it. I nearly said head down, that would not do. So they're prone, but their feet down. And then an hour before you are due to stop proning, you turn the feed off, you turn the patient, you check position, and you start the feed again. And that really does lessen the risk of aspiration. BAPEN have caused a bit of controversy because with other national organisations, which does include the Association of Anaesthetists, the Royal College of Anaesthetists, Intensive Care Medicine and Intensive Care Society, we've written an Aide-Memoire for NG tube placement checks before first use in critical care settings during the COVID-19 response. And we say, do not use pH testing to confirm placement before first use in view of the increased risks of prior unrecognised esophageal regurgitation or respiratory aspiration due to COVID. Once the initial tube position has been confirmed radiologically, then external tube markers and pH testing can be used in subsequent tube position checks. Obviously, never use the whoosh test, air auscultation. Yeah. So the special considerations, and again, when doctors request that X-ray or nurses request that X-ray, it has to be specifically ordered to confirm NG tube placement, because you need to make sure that you get adequate penetration because of that dense ground glass appearance seen on X-rays of COVID pneumonia, because that's what it looks like. Yeah. Leave the guide wire in place until the X-ray has been taken, because again, that does help. They say it improves tube visibility, but I think more to the point, it's actually easier to, if you have to move that tube, it's actually easy to do it with guide wire in. And the X-ray should be interpreted by the person competent in the 4 criteria, which of course, following the path of the esophagus and avoids the contours of the bronchi. It needs to bisect the carina. It needs to cross the diaphragm in the midline and is clearly, the tip of the tube has to be clearly visible below the left hemidiaphragm. They are the 4 criteria. They're important in ordinary X-rays, but in COVID it's even more so. And basically what we're saying is, if you're not sure, seek radiological advice. Mm-hmm. Normally, I mean, to be fair, lots of ITUs all over the country tend to use X-ray first anyway for other reasons. But these are what we are saying. Now, I do believe, but don't quote me on it, there may well have been another event around X-ray confirmation. And so we're trying very hard to keep patients, doctors, nurses safe to make sure this doesn't happen.
Yeah. So the summary is, in critical care, first insertion before you use the tube, the recommendation in that
Yeah.
Aide-Memoire is X-ray, and somebody who really knows what they're doing reading it. And after that, you're back to the normal process of pH testing, checking the tube length as you would normally. Okay, cool.
Yeah.
Now, a few weeks ago, because of a tweet you put out, we confirmed that you and I have been nursing for similar lengths of times. And another thing in the article that really resonated with me was the focus on mouth care. And I always used to be a real stickler for mouth care. You and I have spoken about it in the past, and it's not right in the front of people's minds. So why is this so important, perhaps more important in COVID-19 patients than in the general population of NG-fed patients? And is the care any different?
I think the main thing, it's not so much it's more important, it's just the fact it's less likely to be done because people are puzzled about what they should be doing because of going in, and is mouth care an acid generating procedure, an aerosol generating procedure, which it isn't. And that's what I really found out, it's crucial. But what I didn't realise was in a dirty mouth, you get bugs. And these bugs will sit in the mouth and then they'll think, okay, so dry mouth, I don't like it, dirty dry mouth. No, I need somewhere nice and warm and moist. I know, I'm just going to frolic down the airways and I'm going to go and sit in this nice lung. And that's how people get aspiration pneumonia. That is how enteral patients, a lot of the time, get aspiration pneumonia because of poor mouth care. Speak to any speech therapists, they will wax lyrical about it. So I'm thinking, COVID, patients are really going to be at risk. Their immune system is under all sorts of attack, and staff might be worried about doing mouth care for patients with COVID-19. If people do read my article, if they don't read anything else, just read this mouth care. I can't stress this enough. Obviously, if a patient can brush their own teeth, then that's fantastic. That kind of saves a lot of issues. Don't use an electric toothbrush. Now, ordinarily, electric toothbrushes are gold standard in any sort of mouth care, but it can cause droplets because of the vibrations of the toothbrush.
Yeah.
So a nice, soft, medium, ordinary toothbrush. If they have a dry mouth, obviously, encourage sips of fluid, but there might be no by mouth because they might be ventilated, etc. And in that case, we would obviously hydrate the toothbrush or dipped in water, or apply an available dry mouth product to the tongue, the insides of the cheeks and the roof of the mouth. Really important. Always keep that person's lips moist with other products are available. That's incredibly important. The best sort of toothbrush to use is a small, soft-headed toothbrush with a smear of toothpaste, and you can get non-foaming toothpaste, so that's really good.
Okay.
And if the patient can spit, obviously give them a disposable bowl to spit into. If they can't spit, then you're going to be using bedside suction, but don't forget you've got a COVID-19 positive patient, so you're going to be wearing full PPE anyway.
Yeah.
So that's basically it. It's so important. We need to make sure that the patient produces saliva, and mouth care is a good way of doing it. But also you might even have to put artificial saliva in, because particularly with older people, they just don't produce as much. So that's why mouth care is so important, because you are doing that. The last thing you want to give them is either an aspiration pneumonia or candida, which is so painful. Yeah. Oral thrush is one of the most painful things ever. And we don't want that for our patients, because it's so avoidable. It's so avoidable.
I was saying earlier, because these patients have lost this sense of taste and smell, we don't want to do anything else that's going to discourage them from eating when they're on the road to recovery.
Oh, Marcus, that's a really good point. That's a very good point. Yeah, and a dirty mouth will, I mean, I remember a long time ago, when I was 8 years old, I was a brownie, and there was a badge, and I think it was Good Health, or I don't know what it was some sort of Good Health for brownies, whatever, and it said you wouldn't eat your food with a dirty knife and fork, so why would you not have clean teeth?
Wisdom from the brownies.
Wisdom from the brownies. And I thought, oh, do you know, that's one thing that's always stuck with me.
Yeah.
I'm in 50s now.
For some reason, Liz, I've lost your camera now.
Oh.
But in case we can't get it back, I think that's sort of the end of the discussion, I think, for today. We've covered a huge amount of ground in a short space of time. I think we've already spotted a few things that we're going to want you back to talk about some more. But thank you very much for your time today and for going into a bit more depth and a bit more nuance about some of the things that are in the article that's in the Nursing Times. And again, for anybody who wants to read that, it's called Ensuring Patients with COVID-19 Receive Good Nutritional Care. And I really would recommend that people read it. But for now, Liz, thank you so much for your time. I think we've taken a bit more than we originally promised you. But it's been great speaking to you again. It's been great to be able to see you again. Even if you've disappeared now.
I'm here. Can you hear me?
I can hear you.
Oh,
yeah, I look forward to seeing you again soon. So
thank you very much for having me.
Pleasure. It was a pleasure.
Okay, thanks very much, Marcus. Take care.
Yeah, thanks, Liz.
Bye.
I'd like to make really clear is that unless explicitly stated, the views expressed in the NG podcast are those of the individuals and not those of NG Pod Global or of the organisations for whom the participants work. We hope you enjoy the NG podcast, and if you do, please subscribe or like or both on whichever platform you're viewing or listening to it on.